Hi, good afternoon, everyone. My name is Kiera Baskin, Program Manager for the Day One Doula Collective, and I am here with a special guest, Maureen of Purple Mountain Physical Therapy, and we are going to talk about all things pelvic health. So thank you so much for joining us. If you do have any questions, please feel free to leave them in the comment box below, and then we'll make sure to funnel those questions to Maureen so that you can get those answered. But I'll turn it over to Maureen so she can kind of introduce herself and get started.
Hello. I am happy to be here, Kiera. Thanks for inviting me, and I love having these conversations about pelvic health. It's near and dear to my heart. So I am a physical therapist with a Doctor of Physical Therapy degree, and I have specialized in pelvic health since the 1990s. And my clinic here in Grand Rapids is called Purple Mountain Physical Therapy. I practiced for over 20 years in Chicago. And then I recently moved to Grand Rapids and opened this specialty clinic for pelvic health, EMTM, joint and neck pain. And we're located in Cascade. We're off of Cascade Road near the I-96 exit. And we do have patients that come to us from all over the state of Michigan, actually, because we are known for helping people who have some complex cases and difficult trouble getting really high quality care for pelvic health. So my interest in pelvic health began, well, my first interest in physical therapy began because I was sporty and athletic, which maybe some of you understand that, where you just played a lot of sports. I was a volleyball player, and I played volleyball in college for Loyola University. And when I was in college, I was a biochemistry major, and originally wasn't sure what I was going to do with that biochemistry degree. I thought possibly medical school, but I spent quite a lot of time observing and volunteering in an emergency room and observing physicians in different roles. And I nixed that. In hindsight, I think what didn't resonate with me with the emergency room for sure was that you didn't even know the name of your patient. Sometimes the provider is amazing. That's what American medicine is good at, all of this acute care emergencies. And we, in physical therapy, we really like to have relationships with our patients so that we can help somebody on their journey. And I was a young person, and I was not understanding the role that I could have. I wasn't seeing myself having that role in an emergency circumstance because I didn't want to be a physician that didn't have a relationship with patients. So I nixed the medical school idea for a variety of reasons, that being one of them, and ended up figuring out that I should go to physical therapy school, and always wanted to focus on orthopedics. So that is what I did. I had experience treating every orthopedic condition you can imagine, like blown out ACLs and hip replacements and back problems and neck problems, plantar fasciitis and nerve lacerations in the hand from terrible cuts and things like that. So I have treated all of those and intensely pursued continuing education for orthopedics. And as part of that, I completed a postgraduate training to be specialist for spine problems, so neck and back problems. And this is in the 1990s. And my clinic that I was working at that time decided that they wanted to open up a pelvic health clinic. And what they offered for me was, would I want to get training specific in what was called women's health at that time? Because they felt my background in being the person that helped people that had complex sciatica and back pain and disc degeneration. They thought that I might be able to work with a lot of pregnant people who have back pain. And I really liked the idea of being focused on women. I wanted to be able to raise the level of care that women get. I've always noticed disparities. We all are aware of disparities in our health system and how we are unable to have sometimes equal voices and equal representation. A lot of the studies are done on men, and that leaves out what we need. So I embarked on this postgraduate training specific for women's health. And yes, I was trained to treat people that are pregnant and postpartum, but also individuals that have chronic pelvic pain that might be from endometriosis or interstitial cystitis or chronic SI joint pain or pubic symphysis pain. There's a lot of conditions that cause a person to have nerve pain in the pelvis because, as you know, there's a ton of nerves that go through the abdominal wall into the pelvis and then also out of the spine into the pelvis. So in my training and in my experience, again, going back to the 1990s through today, I have been very focused on developing skills in order to help people that have complex problems, and I love it. In order to be able to effectively treat someone who has pelvic floor dysfunction, you really do need to be able to assess and treat their whole body, because every area influences the pelvic floor and your pelvic bones. For example, if we're speaking with pregnancy, we all understand that in the pregnant state, we have changes that happen in our entire rib cage and in our neck. Hence, a lot of people develop carpal tunnel syndrome. The baby, when you're pregnant, is growing up and disrupting your abdominal wall and your capacity to use your diaphragm effectively and distorting how your ribs are positioned. And postpartum, sometimes all that stuff doesn't come back together effectively. And if I'm working with someone postpartum who has, let's say, stress incontinence, if I were to only treat her pelvic floor, I'm not going to be able to get her better, because the stress incontinence and the pelvic floor are responding to every force that is happening in her body, including the forces that are generated when that person is raising their voice to call their children. And sometimes you may be working with someone who experiences leakage of urine when they are like calling their kids or yelling, and that person is experiencing trouble controlling their intra-abdominal pressure. Kira, do you have any questions in particular that you want me to? It feels a little lonely here. I feel like I'm talking to myself and I don't want to just
Yeah,
go on
no.
and on.
You are completely fine. This is really great information thus far. I know that a couple of the questions that I had and some of the community had was regarding just like how common are pelvic floor issues, and then like what age do you start to kind of see those issues kind of bubble up, or is it primarily like after the birth of a child, things of that nature?
That's an awesome question. Pelvic floor issues are very common. So I have a few answers, but one that will just give you a sense of things. There has been a good amount of research done on female adolescent athletes. So I told you I played volleyball. Grammar school, high school, college, played volleyball. Volleyball involves a lot of jumping, and there's often a lot of landing on one leg. So there's an imbalance going through the forces going up through the body. And volleyball players have been studied and known to have stress urinary incontinence with sport. And these are adolescents, meaning like 12, 13, 14, 15, 16, 17 years old. We also know that we have cheerleading has been studied and found to have pelvic floor dysfunction with urinary incontinence because there's a lot of jumping. Gymnastics has been studied for the same thing. There was just a study published on female trampoliners. I guess that's a sport. I mean, I know that trampolines are used in gymnastics, but I wasn't aware that that was like its own sport. Those athletes have a stress incontinence level very high. I believe it was in the 80 percentile. So we know that anyone who's experiencing unexpected loss of urine with sport is having pelvic floor dysfunction. And with regard to sports, the research seems to be pulling through, depending upon the sport, that it's somewhere between 1 in 4 young ladies and then going up to this 80 percentile. The moves and the risk factors for it seem to be running and cutting and jumping. So if you have a sport that involves any of those, a young lady especially is at risk for pelvic floor dysfunction. We sometimes we do see young boys that may have that as well. A male is less likely to experience urinary incontinence throughout their entire lifespan because they don't have the two outlets that we have that allow us to birth. And because of our outlets, it's a little bit easier for us to experience loss of urine. So that's one answer to your question regarding prevalence, but also at our clinic, Purple Mountain PT, my colleague, Dr. Catherine Klein, physical therapist, she also specializes in treating children who have bladder and bowel control problems. All of those children also have pelvic floor dysfunction. And the most common root cause for kids that are having unexpected loss of urine is tied to constipation. And that's really a highly common problem amongst children these days. So what can happen with kids is that they are not experiencing a full and complete bowel movement every day. They potentially are having bowel movements daily, and the parents might perceive that their child is not constipated, but the bowel movement is not full and complete. And we end up having a backup of stool in their colon, and a child's rectum, which is the bottom of the colon, the rectum in a child is able to like get super large and hold these large stools, and it gets stretched out. That type of stretched out rectum happens when somebody has constipation all the time. And when that is the case, they will have to strain in order to get that stool out. And the straining is an abnormal force going through the pelvic floor and contributing to that person also having pelvic floor dysfunction. And so sometimes with children, we will see that they might come to us, to our clinic, because they're in first grade, and on occasion, not all the time, but on occasion, they are experiencing leakage of urine unexpectedly and maybe having some accidents at school. And it turns out for that person, we do have to treat the pelvic floor dysfunction. We treat everything holistically, whole body. So we're looking at posture, we're looking at breathing, we're looking at their core, we're looking at their neuromotor control, but we're also definitely assessing and screening that child for constipation. And if they have any constipation, we would definitely need to clear out the bowels in order to help the bladder get better, which is the same for adults, but it's really important for children. So
Nice.
Yeah, go ahead.
That's really, really beneficial information. So another question is related to age and kind of when you start to see some of those symptoms occur. Would we also see some of those same issues in infancy or more so in adolescence?
There are infants who are not having bowel movements regularly. And those kids who are struggling from day one can potentially benefit. We don't work with infants, but they could potentially benefit maybe from chiropractic care, who specializes in helping sort of working on the neurologic system of what's going on with those kids. So if you're having an infant that is having problems, there are options, and I would bring it to the attention of your pediatrician and figure out what's going on. You know, when a kid is born by cesarean birth, they are not having the same microbiome that they would have if they had experienced a vaginal birth. And sometimes that might be throwing off their gut and capacity to be able to digest food completely and experience bowel movements.
Nice, thank you. I want to back up just a little bit for some of the folks who may be tuning in about your pelvic floor. Like, what makes up your pelvic floor? Because I don't know a lot about it. So I would just be interested if you could give a little explanation on like what muscles make up your pelvic floor.
Oh, yeah. So I have my model. So first, I will show you my pelvic model. And then I'm going to show you a different model that'll make it easier for you to understand. So we have the pelvic model, and these are the bones of your pelvis. I think you'll recognize the lower lumbar spine. And then we have the bones here in the front. and then the pubic bones there. Inside, we would have the rectum and the uterus and the bladder. So I'm going to take that out. If we tilt inside and we look inside, everything red here, these are the pelvic floor muscles. And if we end up going this way and we look from the outside, you can see all the skin has been taken away here. And these are the pelvic floor muscles. So we would have the vaginal opening where you might insert a tampon, and then we would have the anus here where you would be defecating. Everything red are pelvic floor muscles. And these muscles sit obviously at the bottom of the pelvis. You would have your hip here. This is the socket of the hip. And so you'd have your hip here. And above this, you're going to have all of your abdominal muscles attaching. And then sitting on this, you have the organs that I told you that are sitting on top of those muscles. These muscles perform a huge function for us. They have a lot of roles. One is to support those organs because they're kind of a hammock underneath the organs. Another thing is the sphincteric control, where they're holding in your pee, they're holding in your poop. If you're somebody who is able to walk around and enjoy life and usually not experience loss of urine or loss of stool, then you know your pelvic floor muscles are working at some level. So that's good to know. These muscles also serve a postural function. That's a really important thing to know for any of the doulas or birthing people that are listening or watching for this, because these muscles are part of your posture. If you're pregnant or postpartum and your posture is somewhat altered, and let's say your pelvis is tilted a little bit, or you have changes in your rib cage orientation, or your head is forward because you're always looking down feeding and nursing a baby, when your posture is altered, you're changing the forces on the pelvic floor muscles and potentially changing their capacity to do their job all day long. So the pelvic floor muscles are really, really cool and special because they have a low level of activity going on all day long. They almost like never get a break because they are supporting everything. They're giving you a little bit of holding in the pee and the poop all day long because your kidneys are creating urine and filling up your bladder all day. And we don't want to lose that. So these muscles have this automaticity that is happening posturally, and they never get a break. The other thing that these muscles have that make them very special is that they have branches of nerves in them that are from the autonomic nervous system. So most muscles that give us like strength, you know, biceps and everything, like your muscles, most of those muscles only have central nervous system innervation, meaning like the brain and the brain and the spinal cord are putting a nerve in the muscle, and that makes the muscle able to contract or relax. The pelvic floor muscles have that, and they also have something special, which is autonomic nervous system in them, which is part of autonomic nervous system is your nervous system that helps your pupils dilate or constrict. It helps your heart rate speed up or slow down. It makes when you're feeling chills and your hair stands up, that's autonomic nervous system. So, and autonomic nervous system also is your fight or flight system. So if you're somebody who experiences anxiety or just is having like a lot of like nerves going on, your pelvic floor is going to have that. And the pelvic floor will react to changes or imbalances in your autonomic nervous system. And when it does react, sometimes what we see with our patients is that the pelvic floor can become adaptively tense. We call that a short pelvic floor. Sometimes it's called a high tone pelvic floor, and that's the most common disorder that we see. So the pelvic floor muscles are already primed to go towards a bit of tension because they're at this level of activation all day long. They're not meant to be like relaxed. They're meant to be a little bit going for you all day long, and we want that. So they're like good little soldiers. And then you layer on that a super stressful day or a trauma related to pregnancy or labor and delivery or something that happened in your family or your work. you layer on these life moments that are high stress for us, the pelvic floor often responds to that and is like, whoop. When those muscles do get extra tense in there, that is giving a signal to the spinal cord in the brain. And some of that signal can be, I need to pee. So those patients for us often are like, they can come to us and have a ton of symptoms, but one of their symptoms is, gosh, I'm peeing all the time. I used to be able to hold my urine like a camel, and now I'm like, holy cow, I've got to pee 3 times when I go out to dinner. If you're constantly feeling urinary frequency and you go to the bathroom, but not a lot is coming out, you know that it was an inappropriate urge to urinate, that's a sign of pelvic floor dysfunction. Now, I want to give you a look at those same muscles. So these muscles, if we just flatten them out and showed you this way, I think you might understand a little bit more. So this is the vaginal opening, and this is the anus. This is your pubic bone. Here's your tailbone. Everything colored is a pelvic floor muscle. And you can see the muscles go from the pubic bone. This green one goes around the rectum and back to the pubic bone. This muscle goes from the pubic bone all the way back and attaches to the tailbone. Look at all the muscles attaching back at the coccyx, the tailbone. And then look at all the muscles attaching at the front near the pubic bone. For our pregnant people, we know that 2 common conditions in pregnancy are SI joint dysfunction or SI joint pain and back pain, and that SPD, the symphysis pubic dysfunction, where your pubic bones kill you. Sometimes that is also called lightning crotch. It's really painful. And when an individual is experiencing either of those pains, we know that there's a lot going on where your pelvis might not be balanced exactly right. There's a variety of things. And remember, we're treating whole body, so we're going to figure out what those things are, including like your foot and ankle might not have enough motion when you're taking steps, so you're forcing extra force up through the pelvis. But one of the things we always know is happening if you're having those pains is these muscles tend to go into a bit of overdrive in order to try to protect that joint. So if your pubic bones are killing you, look at what these muscles are doing. They're attached to the pubic bones and they're going to be like, oh, I want to help you out. So they go, and you get a ton of tension there. And then if you have tension there, that is going to be the muscles are attached to the bone. So the muscles are tensing and pulling on that bone, potentially exacerbating your pubic pain. Also, in this area where the muscles attach at the pubic area, you've got your urethra where you pee. So you may experience any sort of problems in the pee zone. That could be urinary leakage unexpectedly. It could be leakage, could be stress incontinence that we all are most familiar with as ladies. We're most familiar with the stress incontinence, which is you try to do jumping jacks postpartum and you lose your urine with that, or you lose urine with laughing, coughing, sneezing, or what I was speaking about earlier. You're like raising your voice to call your kids for dinner and you lose urine. Those would be considered stress incontinence. There's also urge urinary incontinence. Urge incontinence occurs when your bladder is filling up and it starts to give you tons of spasms to say, I need to pee now. And then you try to go to the toilet, but you can't get there quickly enough and you lose a small amount or the whole amount of the urine content, urine volume. And we help individuals who have anything along the spectrum of bladder dysfunction like that. We also work with individuals who have something totally different, like neurogenic bladder and interstitial cystitis, which is a chronic pain condition that shows up with bladder pain. Going back to the tailbone, all these pelvic floor muscles attached to the coccyx, and you can imagine if you are having any pain back here in your back. So let's say my SI joint kills me or my lower lumbar spine is really painful. I have sciatica. These muscles, again, tend to go towards a spasm. We all are kind of familiar with, if you have back pain, a lot of times you have back muscle spasms and it feels super tight. The same thing happens to these pelvic floor muscles. They can get like, whoo! And because these muscles attach directly to the coccyx, we see a lot of tailbone pain. We treat tons of people who have tailbone pain, and definitely we're able to get that better. If you experience any pubic pain, tailbone pain, SI joint pain, low back pain, we can definitely help you with that. Hip pain too. So when the muscles are attaching to the coccyx, it can cause the tailbone pain. It can also cause a force going through the coccyx that is pulling on the SI joint, because the S part of SI joint is sacrum. The sacrum articulates with the coccyx. So you've got the sacral bone and the coccyx. You can see that better here. Here, you've got your sacrum, which all you doulas are familiar with the sacrum. And then you've got the coccyx. So these two bones form a joint here. And because your pelvic floor muscles are attaching to so many of the parts of those bones, pelvic floor dysfunction will cause those bones potentially, you experience pain in that area. Speaking more about the superficial layers of the pelvic floor, so these are the deeper layers, more the levator ani that I think a lot of you have heard of. But if I turn this over and I want to talk about the superficial layers, so now we're talking more about these, the muscles that are on the outside. These muscles are really crucially important. And these are the ones the doulas would know, and midwives, anybody who's involved in the birth world would understand. If a person is experiencing an episiotomy, these muscles are going to be cut, because we take scissors to that area and we cut those muscles. And there's some difficulty once a muscle's been cut with getting that muscle to be working again. If you've had an episiotomy, I had one and I did not want one, but you're working with your provider. I had an excellent provider, and she and I were, you're a team with your provider, and you just have to trust your provider is going to make the best decision for you. And sometimes things happen to you that is not what you wanted, and you have to process that and move on. And I can tell you, if something happened to you in your labor and delivery that was unexpected and what you didn't want, you can be whole again. You can feel like yourself again. You do need, I would encourage people to get counseling to work through processing your trauma and get the support you need. I would encourage you to do physical therapy for your postpartum recovery. It's amazing what the physical therapy can do for you, because I work with people all the time who are postpartum, like they just had their baby, 4 weeks ago, or maybe they had their baby 2 years ago, or maybe 15 years ago. It doesn't matter how postpartum you are. If your body never fully recovered, we can help you. So if I'm speaking to these muscles, if you have difficulty with those muscles, not only, I only mentioned episiotomy, but those muscles might have gotten excessively stretched or had some difficulty related to labor and delivery, or there could have been a tear. Then if you have difficulty with those muscles, our patients who have trouble with that sometimes will report to us a variety of symptoms. It could be the leakage of urine again. It could be leakage of gas, because look at this, we're right near the anal sphincter, and that sphincter needs to hold in that gas. And if you had any difficulty there related to birth, or maybe not even related to birth, it could just be you, then you might unexpectedly lose gas or lose stool. And physical therapy, we can help with that. We work with people all the time who have that. And a lot of times that's a private problem. All of our problems in my field are private. And that's why we offer private, comfortable treatment rooms for patients, and you're working one-on-one with your physical therapist. But also, what I find is women out in the public will, when I mention that I'm a pelvic health physical therapist, some women are very free to say to me like, oh, I need you because I jump and I pee myself. And you do need me or any other help, person to help you. You should not be experiencing urinary incontinence in your lifespan. You should not. So I want to make that clear that urinary incontinence is something for which there is good, solid treatment, and you should get that treated. Having urinary incontinence in our elderly years is a risk factor for us women who tend to outlive our spouses. It's a risk factor for us having to be placed in a nursing home. And that's like serious. It really is. If you have this problem today and you're 35 or 42, don't just live with it. Like, first, there's no reason to. It's like, not, who wants to have that? And it can slow you down and make you not practice sprinting at the gym, because it happens when you sprint, but it doesn't happen otherwise. But that problem is not going to get better as you age. In fact, as we head into menopause, our estrogen goes down, and our risk factor with having lower estrogen, our risk factor for incontinence raises, and for urinary tract infections raises. So we want to get this treated. Just don't live with it. Like, you deserve to have the care that, like, you deserve to be feeling healthy and whole. And in America, and actually around the world, there are countries that do it, better than us. But in America, we just don't support people through their birth recovery. It's considered like, congratulations, mama, you did a great job. You had a healthy baby. You might see your provider at 6 weeks and you're told that you are good to go, but you're not given any direction on how to proceed. And the truth is, at 6 weeks, most people that I'm working with really have very little libido. They're not interested in intimacy. They don't know where to start to properly recover their abdominal wall. Usually they have a diastasis recti abdominis, and we assess and treat every one of our patients, whether pregnant, postpartum or not, male patients, kids. We assess every patient for a diastasis recti abdominis. And that's because those abdominal muscles are so important. We want you to have integrity through your abdominal wall. Having the diastasis recti abdominis, that is normal to happen in your third trimester, totally normal to happen. Having that recover effectively is crucial for your well-being. It's very important for you to be having the integrity of your abs, because we all know that with back problems, a lot of times there is a weak core is what we hear. Well, what do you think is weak? The abdominals aren't working well if you have a diastasis recti abdominis that is having load transfer problems. And that's one of the things we look for with DRA. And I could talk more about that if you're interested, but I'll wrap up speaking about these superficial muscles. One of the common conditions that we treat here is vaginismus and painful sex. So it's very common that we would have pain. It's really common that a person would experience pain when they're trying to have any penetration. And if that is you, that is a sign of pelvic floor dysfunction. There are other things that can contribute to that. So we always do want you to see your physician and just make sure that there's nothing else going on. Physicians do have some things that they can offer to treat that, but really the most common thing is in our wheelhouse with this pelvic floor dysfunction. We really routinely are finding that individuals who experience painful intimacy will have trouble along any of these muscles here. And usually they have some trigger points and troubles with these muscles here. And we're working with people regularly who have been in committed relationships for a long time and have never had penetrative sex, or used to have it. And now, 3 years ago it was okay. And now the last couple of years it's really painful. So they're not having that very much anymore. And there's a lot of grief that goes along with that. Sometimes there's shame, it's just really harmful on us. And if that is you, I want to support you. You have done nothing wrong. This is really painful intimacy is something that unfortunately you are experiencing, but there is really high quality help. Getting the care from a really well-trained pelvic health physical therapist can honestly change your life. I get cards mailed to me from patients. Like I have 2 patients right now who are pregnant, who were not able to have any intimacy, and that's what they wanted. They wanted to be a mom. And how frustrating is that? And so together we're able to get that goal taken care of. And the care for something like that, again, whole body. You got to go up to the thoracic spine and the low back and the inner thighs and the abdominal wall, and make sure that you're looking at all of those areas, because the pelvic floor, again, reacts and responds to all of that. And some of the nerves that go into the pelvis or the abdominal area do come out of the thoracic spine. So we have to clear and treat that whole situation. Kiara, I saw you said something in there. Let me see what your chat said. It was something about diastasis.
Yeah, we just have a few folks in our community who aren't necessarily familiar with that term, what that looks like.
Great.
So if you could just explain that a little bit.
Okay, great. So diastasis recti abdominis is a condition. Well, first, let me tell you, going to the anatomy of the abdominal wall, I'll stand up. We have our six pack, supposedly, that is an abdominal muscle of rectus abdominis here. And then there's one here, and they come together and they have a seam. They go all the way from your ribs down to your pubic bone, and they're supposed to come together in a seam. And when we are pregnant, it is normal to make space for the baby and normal for this to separate and widen. That area in between is called the linea alba. And when you're pregnant, the linea alba also often turns a darker color. So if you have that line of darker color, then you know exactly the anatomical area I'm referring to. When the muscle separates in order to create space for the baby, it's totally normal. Research shows typically it is just about every woman who will experience a diastasis recti in the third trimester. We don't want to be seeing them in the first and second trimester. And I do see them in my patients who are having their second pregnancy and they never rehabilitated properly after the first one, or their third or their fourth pregnancy. So that's why in between pregnancies, we would like to see you doing the rehabilitation to recover your abdominal wall so that you can go forth, have more pregnancies, or don't. But if you do want to have more pregnancies, we would like to have your next pregnancy happening and beginning with an intact abdominal wall. With a condition called diastasis recti abdominis, the abdominal wall separates to make space for the baby. And what happens with a problematic DRA is the abbreviation for that. A problematic DRA is unable to load transfer effectively. So what that means, to put it like simply, is that every time I move and like take a step with my legs, if I'm taking any steps or I'm lifting my baby up or taking groceries into the freezer, anytime I am moving, my core needs to activate to stabilize my trunk, my spine, my pelvic floor. All of that needs to activate and transfer that load. So the load is going from one leg to the next leg, one leg to the next leg. Well, it goes from the leg. Let's say I take a step with my right foot. The force goes up my right foot, through my pelvis, across my abdomen, and down to my left foot as I'm walking. The transfer of load from the right side to the left side to the right side to the left side, it happens without us thinking about it all day long. I mean, that's just natural mechanics of moving. When you have a diastasis recti abdominis, you have this gap in separation and the load can't transfer effectively. That shows up for us as having a bulge in our abdominal wall or sometimes a caving in our abdominal wall. So women, a DRA is the most common question I get, actually. That and the stress incontinence with like jumping jacks and jumping around. Those are the two things I get asked most commonly all the time. I'm on Instagram with at Purple Mountain PT, and people will DM me wondering if they have a DRA. It seems to be something that is discussed on social media. If you have an abdominal wall that appears like you are pregnant, but you're not pregnant anymore, and you're not 6 weeks postpartum, let's say you are 4 months postpartum and you still really look pregnant, you possibly have a problematic DRA. If you have an abdominal wall where you try to do a crunch or a sit up, or you're lifting your kids and something kind of bulges out and you're like, gosh, why is it bulging? That is a problematic DRA. When an individual has this problematic DRA, it cannot transfer loads effectively, and they end up experiencing a whole number of symptoms. Women are often concerned about the physical appearance. I'm okay with appearance, but I'm not okay with the function not working well. I think our physical appearance is beautiful if we've just like created another human being and we've grown extra skin. So it might not always appear the way it did before you had children. It shouldn't. So I'm okay with appearance not being fabulous, but when I'm checking someone for a DRA, I want to see how does the area accept load. When you're lifting up your kids, can your abdominal wall and your core muscles take that? When you're getting out of your car and you're stepping out of your car, can your abdominal wall take that? If you're having troubles with a DRA, you may be at risk for back pain, urinary incontinence, pelvic organ prolapse, any number of things like the pubic problems that I was talking about earlier, because those abdominal muscles attach to the pubic bone. So if the muscles are separated, now we have some dysfunctional forces going through the pubic bone. There's a whole bunch of things that we would want to make sure are not happening for you. And our diastasis recti abdominis recovery program here is really comprehensive. Patients tell us, like, nobody's ever checked me like that. It's really common that I have people come to us and say, I know I have a DRA, somebody told me. And usually it's some other provider told them, oh yeah, you have one. But they're often told you have one, and then they're not told what to do to get rid of it and how to effectively get rid of it. So I don't understand somebody saying you have one and not having the capacity to help somebody resolve it. You can definitely resolve it. Some are buggers. I did have a DRA that was actually really bad, and my DRA, I told you I've been a pelvic health PT since the 1990s. Well, I didn't have kids until my daughter was born in 2005. So I already knew a lot of good stuff about how to heal a DRA. And then I got one that was bad and embarrassing. You're like, why do I have this? I'm athletic. I'm a physical therapist. I shouldn't have one that doesn't go away. And I did. One of the things that we know is a risk factor that's recently been flushed out is gestational diabetes. Well, I did not have gestational diabetes, supposedly, but honestly, I think maybe I had blood sugar levels that were like going the wrong direction. I generally eat healthy anyhow, but I probably could have done a better job with that. And I do wonder if maybe that was some reason why it was tricky for me to get rid of my DRA. But I did the work. In most of my patients' cases, we can get their DRA better in what I would consider a short period of time, like 6 to 12 weeks, it gets much better. And then sometimes after that, there's still room for improvement, but it's really quite better. For me, it was like 9 months, and I did the work. And that's what I offer my patients, and what my team here offers our patients. We know how to assess, we know how to treat. And the research related to how to properly rehabilitate a DRA has changed over the last 15 years since I did my own. So there's things we know now that are safe to do that previously we were told not to do. For example, if you are Googling DRA, you are possibly going to run across old, outdated information that might tell you something scary, such as you cannot do planks. That was something that was widely considered truth at certain points. I never thought that to be true, but in the DRA recovery world, that was something that was considered potentially harmful. That has been debunked. We know that that is not the case, that planks can be okay to help a person recover their DRA. I say can be because it depends upon you and your body. That's why we are assessing every person. Our assessment, if you want to know if you have a DRA, we're going to be checking you doing the planks, doing side planks, doing all these different functional movements. And we want to see when you're lifting, all these different things. We try to find the point of weakness, and we try to teach you how to change your breathing mechanics, your core engagement, and your pelvic floor engagement to optimize the pelvic floor and the abdominal wall during those activities. And we create a program for you that is graded and appropriate for your body's breaking point, essentially. Because some people come to us with a DRA, and I'm able to really put them through a high level program that their body can take, and I can teach them how to effectively control their diastasis recti abdominis with the high level activities. Then I have other people where we have to begin as beginners. Of course, that's natural. Some of us, our abdominal walls haven't worked well for years, so we just need to start with the baby steps. So I see a question here. Okay, how does therapy work? What does it look like? How long does treatment typically? Okay, if you're speaking to the diastasis therapy, well, every appointment begins with an evaluation. All of our appointments are private with the same physical therapist. We have designed our treatment and our clinic for the benefit of our patients to get you results. That means we believe it's really important that you have a trusted relationship with your provider, and that what we did last visit with you, you come back, we talk to you about how did you feel, what worked, what needs to change, what are you noticing this week, and then we modify your program this week based upon the knowledge of how we know your body and what we did last week. That is important, we think, to have this continuity of care with the same provider instead of bouncing around to other providers. Each of our appointments is up to 55 minutes long, and that's because we found with this whole body care, we want to have the time to give you everything that you need. For a diastasis recti recovery program, that would be something where we're working for these 55 minutes together. Quite often the program is exercise-based, which I talked to you about, and it's customized to you, but we also use a ton of myofascial work and visceral work in order to try to free up some of the tension through the forces that are contributing to your propensity to have this diastasis. So I've mentioned that pregnancy changes the rib cage. Well, if the ribs are flared, that's going to pull the abdominals apart, contributing to the diastasis recti. So we will work with manual therapy and joint mobilization and nice feel-good work through your thoracic spine and through your rib cage in order to optimize the rib position to decrease the strain through the abdominal area. We also include visceral mobilization. So that is like abdominal massage. People love that. It makes them feel so much better, especially anybody who's postpartum. We are always assessing and treating the entire abdominal wall with massage techniques. If a person had a cesarean section, we are working on your scar and making sure you're not developing adhesions and making sure that scar can move effectively. Scars should not pinch, they shouldn't pucker, they should not be excessively sensitive when you have underwear on top of them. If that is the case, we can help your scar. We work with every single scar that any of our patients has, even if it's a 30-year-old scar from a gallbladder being removed. Scars are really important parts of us getting you moving well. The therapy that we do also involves teaching you what to do for yourself. So like I had 2 postpartum people here today that I'm thinking of who we have whole body vibration machines, and we use those with the exercise program in order to work on their balance and their neuromotor control and to try to improve their engagement of their glutes, because these people had some gluteal firing problems that we see a lot, as well as the abdominal wall recovery. So for anybody who comes to us, let's say somebody comes to us and the only problem they have is a diastasis recti abdominis, we would want to really make sure that's the only thing you have going on. It's very rare that someone literally has nothing else. They never lose urine, they never have back pain, they never have hip pain, they don't have anything else. But if that's all that you have, then we would come up with a program that is going to be assessing and treating your DRA with the manual therapy methods I talked about and the exercise-based methods, and then giving you you specifics on what you need to be doing at home for it. I told you for myself, I had a program for 9 months, and every single day I did my stuff. Now, I can be intense, and I was really highly motivated to get rid of mine. And it seemed to take that level of effort. With my patients, it usually doesn't take daily effort. But if you're somebody who wants to put in that kind of intensity, I can build a program for you. So you said, do I recommend all postpartum folks see a pelvic floor therapist after childbirth? And how does someone begin care? We do. We believe that every person deserves to be assessed and treated by a pelvic health physical therapist following any pregnancy, including miscarriages. And I'm sorry if you're someone who has experienced those. I know that the loss of that can be devastating. And a lot of times we aren't provided any support for how to recover from that, including if you've had a D&C. But we're here to support people through that journey as well. Quite often the emotional tension that developed in there caused the pelvic floor muscles to go into some dysfunction. So we can help individuals with that. But anybody who experienced a pregnancy, we would recommend that you would see a pelvic health physical therapist, because we are the rehabilitation specialists. Your entire posture changed, your breathing changed, your pelvic floor had a ton of weight going through it. And if you went through a vaginal birth, you had a massive amount of stretching happening through there. If you tried for a vaginal birth and then ended up with an emergency cesarean, then you had kind of both happening. You might have had some pushing and some contraction happening and the cesarean. If you only had an induction with a planned cesarean, you had all those abdominal tissues cut. They try not to cut the abdominal muscles, which is great. They try to separate them, but there can still be troubles in that area with that scar tissue. We tell all of our people that we are working with that in pregnancy, you should not experience any loss of urine and you should not experience pain. Now, we know that Braxton Hicks can hurt. Sometimes there's some round ligament discomfort. So some of those things would be like, okay, you could have some of those and not need physical therapy. We always want you working closely with your provider. If you're having any pain, you have to call, meaning your physician or your midwife. If you're having pain, reach out. They would rather you call them and just make sure everything's all good, or make sure that you can get checked out, than have you at home worrying about something. So always call your provider. But if you're pregnant and you are experiencing pain that would be what we would consider kind of orthopedic pain, like I'm pregnant and my back hurts, I'm pregnant and my pubic bone hurts, I'm pregnant and my hips are killing me every time I roll in bed, anything like that, or like crotch pain like that, we see that a lot, or swelling down there. Then if that is the case, we can help you to get proper care for that. In fact, we just saw somebody who's in the last week of her pregnancy and had reached out to us with a Google search, because this week she developed, well, it sounds like it was last week, maybe 38 weeks of pregnancy, developed severe pain. Sounds like it's SI joint pain and pubic pain, and it sounds really painful, like hard to get out of bed type thing. And she called us with like a 2 a.m. Google search, trying to find somebody who would be able to help her, because now she's worried about her ability to go into labor and delivery. And yep, we can help that person. Now that person, I did want that person to call her provider. So I got a voicemail from like 2 a.m. So I get to work, and my advice was, I need you to call your provider and make sure that everything is good, which that person did do, and went to the provider, and the provider said, oh, physical therapy can't help you. So, which is not true. Like you only have like 5 to 10 days left of this pregnancy, and you're heading into a labor and delivery, and you're telling me you can't really even move right now. For sure, we could help you. We would do very gentle stuff that will balance out your pelvis and try to get everything better aligned. We could teach you body mechanics. We could give you suggestions for birthing so that there might be less strain going through there. There's so much we can do. So Sometimes I think providers themselves don't know what we can do and how we support them and their patients through their journey. In terms of how people can get started with physical therapy, they can get started in Michigan anytime they want. You just walk into a physical therapy clinic. You don't need to have a prescription. You can just get started anytime you want, just like you would be walking into, a grocery store to go get your groceries. You can get started with a physical therapist and choose to see whoever you want to see. If we're working with someone who's pregnant, my preference as a provider is that you do have a prescription. I want to make sure that your midwife or your OB-GYN is clear and I'm on the same page with them with regard to what I'm doing for you and with you. We see people at any stage postpartum. So I have my experience in Chicago for 20 years was working very closely with some of the major medical centers, including Loyola, Northwestern, and Rush. Well, Northwestern is one of the busiest birth centers in the country. Some days of the year, they birth more babies than any other hospital in the country. So it was a real privilege to be working so closely with their providers. And they have a traumatic birth injury recovery program that includes physical therapy. So as a result of being closely aligned with providers at Northwestern, I've treated a ton of pregnant and postpartum people. And so some people postpartum we would see right away, like maybe you're 4 or 5 days postpartum, you've just gone home, but something happened in your labor and delivery and you need help learning how to pee again or walk again or anything. If you need that support, we are here for you and we can help you. If you are having what you would consider to be kind of a typical recovery in those first 6 weeks, meaning you have some pain and discomfort as in the first few weeks following labor and delivery, that would be considered normal, but you're not having SI joint pain, back pain, pubic pain, a ton of pelvic pressure. You're not having any trouble peeing or pooping. If you're having kind of a typical smooth sailing recovery, then we recommend you see your provider at 6 weeks and then you start physical therapy at that point. Anyone who's not smooth sailing, you come in within those 6 weeks and we can help you out. So we work with individuals within those first 6 weeks who have trouble peeing. It's common that people might have difficulty with being like, they either don't feel an urge to urinate or they sit on the toilet, they can't get their urine to come out. Those can be some serious things. And if you are having any difficulty peeing and getting your urine out and feeling your urge to urinate, you have got to call your doctor. That is a very important circumstance. We all should be peeing every 2 to 4 hours. You don't want to go all day not peeing. You're overstretching your bladder and potentially damaging it. So if you are having trouble peeing after having your baby, you have to call your doctor and you should go to physical therapy. We can help you. So that is really an important thing. And I don't think most of us know that because it's not told to us. You're not thinking that you're going to have trouble having pee. You have trouble peeing. What else? And typically we're working with individuals once a week for those private appointments, the 55-minute appointments. And we just build your program according to what you need to help you meet your goals. So there was somebody that I was working with, a different person that I was working with today who is postpartum. She brought her kids. I love it when people bring their kids, their little ones. So we are fine with you bringing your children to appointments if you don't have any childcare. I love seeing kids. That doesn't bother me at all. Just recognize that if it distracts you or, it might slow down what we're able to accomplish during that time, but we are here to support you in what you need for yourself and your family. And I totally get it. I'm a mom. Not you don't always have people at home that you trust, or if you're nursing. I have moms here who come all the time nursing and the baby's really young. The baby will sleep a lot of the appointment, but then the baby might need to nurse. So that's easily accomplished. The mom can nurse the baby during the appointment when the mom is receiving manual therapy. So I could be working on the mom's back and she might be lying on her side, nursing her like sweet baby. It totally
That is
works.
really, really amazing, Maureen, to hear that. Just one last question before we wrap up here, because I want to be mindful of the time. Do you currently accept insurance? Our service has private pay? And then also, where can we find you? Are you on social media? And yeah, we just want to make sure that we have your information to be able to share.
All right, yeah. So we are out of network for insurance. So the way it works is individuals pay at the time of the visit, and then if they have commercial insurance, they can submit their super bill to their insurance. And everything we do is normal physical therapy codes. And then our business is Purple Mountain Physical Therapy, and the website is www.purplemountainpt.com. And then I'm on Instagram, and you'll see a ton of stuff. I'm pretty active on that. So that the handle there is at Purple Mountain PT. And if you're interested, please follow me, because this year I am having speakers every month with free speakers coming, including, I'm super excited about it. On Wednesday, April 13th, I have Jennifer Holshoe, who's a midwife, coming to speak. Kiara, do you know her?
Yeah, we're
awesome.
very familiar with Jennifer.
I love her, and I'm so grateful she's going to share her time. So anybody can sign up for that. You can come here to our clinic to meet her in person if you might be interested in learning about what she could do for you. Or we're offering it over Zoom live, 6 p.m. Wednesday, April 13th. Or if you can't attend live, that's dinner time. Just sign up anyhow and let me know, and I will send you the recording. So the sign up for that, you can call my clinic, Purple Mountain PT, and get yourself registered. So our phone number is 616-516-4334, or even easier, follow me on Instagram at Purple Mountain PT, and there's just a link in my bio, and all you put your name in there and your email address, because I will email out the Zoom links the day of the event, and you can put your questions in there. So any questions you might have to a midwife, I would love it if people would come, and please feel free to spread the word. I am a huge supporter of midwives. I have seen a lot in my years of doing this, and I will tell you, the midwives in West Michigan are fantastic. And you can have a really wonderful and whole birth experience in whatever setting you choose. You can. You, as the person who's experiencing that, you need to prepare your mind, body, and spirit for that, and you're going to be good. But one of the way of preparing your mind is knowing what your choices are. And one of your choices is a midwife. And I would encourage everybody to take advantage of this free chat I'm having with Jennifer Holshoe of West Michigan Midwifery, because it's going to be good. I've got some questions, and I would love to hear your questions.
Yes, well, thank you so much, Maureen, for sharing your wisdom and your expertise talking about pelvic floor health. Like, this is going to be an amazing resource for our community members to tap into. I would love to, eventually have you come back and talk a little bit more about some of the other questions that we may get. And then we will also connect so that we can have your information to share with folks in our community. But that is all that we have for tonight's session. Again, thank you for everyone for tuning in, and Maureen just for spending some time with us. And if anyone, like I said, has any additional questions, please feel free to drop your questions in the comment box, and we'll make sure to get those to Maureen. And then we will also make sure to share the information about her upcoming events. Awesome. Thank you.
Awesome. This was so fun. Thank you so much for supporting the birthing community.